So I'm excited to introduce our next presenter, Dr. Jennifer Hollywood, who is coming to us currently from the University of College Cork in Ireland, where I believe her career started, but then she was on the other side of the globe at the University of Auckland in New Zealand for a number of years, where I believe she's still collaborating with researchers there, and she has done a tremendous amount of things as it relates to cystinosis, only some of which I think we're going to hear about today. So thank you, Dr. Hollywood.
Thank you. Thanks, Clay, and thanks very much to the organizers for inviting me to speak today. It's my first time at the Day of Hope conference, so it really is an honor to be here. And as Clay said, yes, I've recently moved just 3 weeks ago to the University College Cork in Ireland. So it was a bit of a shock leaving the New Zealand summer for the winter, but it's nice to have a trip to San Diego now to get a bit of warmth back. So I'm going to talk to you mainly about the work we were doing in New Zealand over the past 10 years that I was there. So, as you all know, there are urgent needs for new treatments for cystinosis. The main therapy that everyone gets is histamine, and this drug is really good at removing cystine from the lysosomes, which we've seen throughout the talks today. And it is able to delay progression of disease, however, it is not a cure. And we know this because patients still progress to the need for kidney transplant. And this is a chemical formula of cysteamine. As you can see, it's a simple chemical with this ammonia group here and this sulfur group here. And the chemical structure is what leads to some of the problems that patients will find with taking this medication. So some of the disadvantages include a bad taste and a smell, which can cause nausea and vomiting, GI tract irritation and ulcers, and it undergoes rapid clearance. So it's you need to take it in high doses, and you need to take it frequently so that you have high enough levels to deplete your cystine. And it's also metabolized into these noxious compounds, and this causes the halitosis, or the bad breath, and the unpleasant body odor. So there's two things that we need to fix for cystinosis, and that is to address the side effects of cysteamine, and also to address the fact that cystine depletion alone does not result in the prevention of end-stage kidney disease. So we've been working for the past 10 years on addressing these two and trying to find some solutions. So to do this, we have developed a number of models in our lab. So as you heard earlier from Dr. Friedman, who introduced nicely the stem cells, we began this work a number of years ago. And what we've done is we take this skin cells from a patient or from a healthy donor, and you put these into a dish in the lab, and then you treat them with 4 genes, and this will revert them back into a stem cell state. And these induced pluripotent stem cells are now able to become any cell type of the body. And as Dr. Friedman said, you can make these turn into kidney organoids, so that's what we do as well. So we've developed our own protocol where we will take these iPS cells, and then over the course of 12 days, with the introduction of different media, we're able to coax them to become kidney tissue. And this then is like a mini kidney in the dish, and this is what we perform our experiments on to find out more about cystinosis and to test new treatments, as it is a human tissue. And if we find any new treatments, we want to be able to test that in an animal model, because before you can progress any drug to the clinic, it does still need to go through animal trials. And there is a mouse model of cystinosis, however, it does have a late onset of disease, so we made our own model, and it's a rat model of cystinosis. So we genetically modified a rat so that it has a mutation in the cystinosin gene, and then we characterized this rat over the course of 12 months to see if it had the cystinosis symptoms. So you can see here in this graph, this is cystine loading in the kidney tissue, and this is cystine here on the left, and this is the age of the animal. So we tracked it from 3, 6, 9, and 12 months, and you can see here that the white bars, that's the cystinosis animal, cystine levels increasing over time. This is a really strong microscope showing you a lysosome with a crystal inside of the cystinotic rat in the kidney. We also have Fanconi syndrome markers, and this is just a few I'll show you, but these rats pee a lot over 24 hours, so this is urine output over 24 hours measured in liters, and this is the age of the rat, and you can see the black here is a wild type or a healthy animal, and the grey is a cystinosis animal. And you can see from 3 months onwards, there's a sharp rise in the amount of urine that's excreted over 24 hours. We also look at the components of the urine, and we can see that they have increased protein in their urine from 6 months, 9, 12, increased glucose, and increased calcium. And you can see here at dissection, compared to a wild-type rat at the same age, the cystinosis kidney is a lot different. It's a lot bigger and paler and generally unhealthy looking. So this disease or animal model has a very similar disease progression to humans, and it does this in a relatively good timeline of 3 to 6 months, and that would be our treatment window. So firstly, to address the side effects of cysteamine, we've partnered up with a group in the University of Sunderland, Professor Herbie Newell and the late Professor Ros Anderson, who unfortunately passed away 5 years ago. But she invented this prodrug, CF10. So a prodrug is just a drug that needs to be activated inside the body. So this again is cysteamine and the chemical formula. And what she did was she added on these extra groups to make cysteamine more tolerable and to increase its efficiency. So she added on these groups. So she added a thioester group, which would protect the stomach, an ester group to improve absorption, and a gamma glutamate group to lower the dosing needed and to get rid of the smell. So we wanted to test that in our rat model of cystinosis. So you can see here, this is one of the cystinotic rats. It's a white rat with red eyes, so kind of cute. And we put the drugs into these jelly formulations. So this is just jelly that you'd have at a birthday party. We'd melt it down, put in the drug, and then make it solid again, and they eat the jelly within under a minute. So we do cysteamine dosed at 30 milligrams per kg, delivered twice daily, 12 hours apart, and this dose was chosen for a reason. I'll get to that a little later in my talk. We also dose them with CF10 at an equimolar dose, so it's the same amount of cysteamine going into the animals, and that's just 82.5 milligrams, again twice daily. And then we also give them vehicle jelly with no drug, so that we know that the effects are what we see is from the drug. We treat these animals from 6 weeks to 6 months of age, so over 6 months, and we do it in male and female animals. But for time today, I'll just show you male animal data. And 6 weeks is before we see any of those Fanconi syndrome signs and cystine accumulation, so that's why we chose this treatment window. And we take weekly body weight measurements, monthly urine and blood collections, and then at the end, we collect all the tissues for our analysis. So firstly, I'd like to show you some cystine depletion. So again, here's the kidney cystine levels, and here's the vehicle with no drug. CF10 and cysteamine bring down the amount of cystine to about the same level. Again, the dose is not optimal, so that's why it's not completely reduced, but there's a reason for that there. And then the liver, we can see again there's a reduction in the amount of cystine in the liver in the, with CF10 treatment, and a bit more at cysteamine. And then any other tissue, we had no effect of either CF10 or cysteamine in reducing cystine at that concentration. When we look at polydipsia and polyuria, so that's the amount of water they drink, so water intake over 24 hours. So in black here is the vehicle or no treatment group, and you can see here that that rises sharply after 3 months. And then in blue, we have CF10 and red cysteamine, and you can see that these don't have that same increase. And this green here is a wild-type animal, so they track nicely with the wild-type, and at the 6-month time difference, they've all converged. Urine output over time is the same, so increases sharply with vehicle animals with no treatment, and then with treatment, you can see that CF10 and cysteamine both reduce the amount of urine that's being excreted. And we look at the Fanconi syndrome markers, such as total protein, and you can see at 6 months, compared to vehicle, there is a significant decrease in the amount of protein being excreted when you use both CF10 and cysteamine. Same is with glucose at earlier time points, and also with calcium. However, with calcium, we see a sharp increase with cysteamine treatment in the amount of calcium that's excreted in the urine. And we've further investigated this to look at why that could be, so we're hoping to find that out. But CF10 did not have the same effect with calcium, it was a less increase. And finally, kidney preservation. So at the end of the study, we take out the kidneys and we look at them at a gross level. So this is a wild-type kidney. The vehicle, again, you can see is quite pale. And with CF10 and cysteamine, we get a reduction in that pale color and bring it back to a more wild-type appearance. And when we look at it more closely at a histological level, so this is just the kidney sliced up and dyed with a special dye so we could see the tubular structures. So you've learned a lot about the nephron today. So this is the glomerulus, and then it feeds into a... Oh, you can't see my thing. Sorry. Oh, no. You can see here a glomerulus, and that feeds into a proximal tubule. So this is a healthy wild-type kidney histology. And you can see not a lot of white space compared to the vehicle, which has these large spaces of white, which is all the tubule dilation and degradation of the kidney tissue. And when we treat it with CF10, we can see there's a big reduction in that white space and also with cysteamine. So some kidney preservation is occurring. And then we do this histological scoring, which is where we take 10 random fields of view and do analysis and have these scoring criteria. So we're looking at proximal tubular atrophy, which is this proximal tubular damage. And in the untreated animals, this is very severe. It's in red. So the percentage of tubules with this are marked at this color scheme. So severe is red, moderate orange, mild is yellow, and no damage would be green. So with these different criteria, we can see that compared to the vehicle, we get some reduction in the atrophy with both drugs and also with the basement membrane thickening, dilation, and epithelial effacement. So these are all positive effects of both drugs. And to conclude from this study, we just conclude that the CF10 and cysteamine are equal in their ability to rescue the polydipsia, the polyuria, to improve Fanconi syndrome markers, cystine depletion, and kidney preservation. I just want to note that the CF10, although this dose was suboptimal, it has been done extensive toxicity tests in dogs by the University of Sunderland team, and there have been no adverse effects or side effects shown with CF10. So although it's not better than cysteamine, it's still a really good alternative because the side effects shouldn't be there, but it's still giving you the same overall protection that cysteamine does. And also to note that the dose that was used in the dogs is 4 times higher than what we've used in this study, so and no side effects were seen, so you can give much higher doses of CF10 also, and we're progressing with those studies soon. The second part of my talk is addressing the fact that cysteamine cannot or doesn't prevent the need for a kidney transplant. So again, going back to our cystinosis IPS models, so these are the stem cells that I talked about earlier. And what we did was we genetically modified them so that they had a mutation in cystinosin to have a cystinotic phenotype. And then we made these kidney organoids from the wild type and cystinotic cells. And then we did characterization studies to see what we could learn about this disease. And what we found was, as well as cystine loading, they also had this defect in autophagy, which you've also heard about today. So it was really well explained earlier by Dr. Jenkins, but again, just to reiterate, so a cell is like your house, and it contains all the components that you need for a functional cell, but you generate rubbish over time, and that needs to be collected and put out into the curb, so the garbage truck can pick it up. So this is the little garbage truck, which is the autophagosome, and it scoops up all the stuff that needs to be degraded, and it brings it over to the recycling center, which is the lysosome. And this is where then the lysosome and the autophagosome will fuse. They'll sort out what they need to keep and what they need to recycle, and then what's needed is returned to the cell, and what's not needed is degraded. And what we found was, as well as having cystine loading in the lysosome, they were unable to complete this pathway. So there was a block here in the autophagy pathway. So what we did was we looked at trying to treat this with an FDA-approved drug. And we chose everolimus, which is an mTOR inhibitor that's already on the market, and it's used for organ rejection and sometimes in cancer therapies. So what we did was we treated these cells and organoids with cysteamine and everolimus, and we found that we were able to get rid of the cystine and also to release this block. And then our cystinotic symptoms were all rescued in this model. So we wanted to test that then in our rat model of cystinosis. So again, we did the jelly pills, we did cysteamine dosed at 30 milligrams per kg twice daily, 12 hours apart, 6 a.m. and 6 p.m. And the reason we chose this low dose was because we wanted to see any additive effects of the everolimus. Because if cysteamine was too high and had a complete rescue, we'd never see the effects of the everolimus drug. And that's why we chose a low dose of cysteamine. Everolimus was dosed at 10 milligrams per day, or 10 milligrams per kg twice weekly, so 2 doses each week. And then the combination was 30 mg of cystamine and 10 mg of everolimus twice weekly, cystamine twice daily, and then of course we had our vehicle study as well. Again, treatment from 6 weeks to 6 months in males and females, body weights, urine and blood, and tissues were collected. So here's the cystine again in the kidney, and this is male data again. And here you can see the vehicle non-treated animals. Cystamine, we see a reduction, everolimus, and then when you add the combination, you can see a far superior reduction to either treatment alone. And when we look at the other tissues that previously had no effect with cystamine, we're now seeing a nice reduction in the heart, liver, spleen, and brain, no effect in lung or muscle. However, these other tissues have now had far superior reduction in their cystine levels. In polydipsia and polyuria, we see here in this wine color is the vehicle, so it's rising steeply after 3 months. Everolimus doesn't have much an effect on its own. Cystamine brings it down, as we saw earlier, and then the combination brings it down a little further. Same with urine. Again, everolimus and vehicle, no effect, but cystamine and the combination reduce the amount of urine that's excreted over time. When we look at our Fanconi syndrome markers, from 4 months onwards, we can see a reduction in the amount of protein that's excreted in the urine. So we see it significantly better at 4, 5, and 6 months compared to cystamine or everolimus treatment alone. And same with glucose. And the calcium now is, they still see the increase with cystamine treatment, and this is reduced with the combination. And I just want to draw your attention to the progression of the total protein. So I've just drawn this line here with the vehicle. So you can imagine the progression of the total protein excretion over time is going to rise again, keep rising. Cystamine brings this down, which is what we know from patients, that their progression is slowed down. Everolimus can reduce this further, but the combination therapy really reduces this compared to cystamine treatment alone. So the progression is going to be far less. And finally, the kidney preservation, we can see again the wild-type kidney and vehicle, quite different. Cystamine brings it back. Everolimus has no effect on the morphology of the kidney, but the combination again brings it back more like a wild-type appearance of a kidney. And when we look at it at a histological level, again, looking at this white space in the vehicle, untreated kidneys, this is reduced somewhat in the cystamine, not as well in the everolimus, but you can see clearly here the combination is a lot more like the wild-type histological phenotype or look, and a lot less of that white space. And when we do our scoring, you can see here with the numbers compared to vehicle, we're getting a reduction in the proximal tubule damage. It's now from 53% down to 37%, so not complete rescue, but very strong rescue compared to either monotreatment. So to summarize that, so combination treatment versus either cystamine treatment alone or everolimus treatment alone, which is monotreatment, it's better. It's better in terms of polydipsia, polyuria, Fanconi syndrome markers, cystine depletion, and also kidney preservation. So to conclude, in terms of CF10, the prodrug in addressing the unwanted side effects of cystamine, it showed equal efficacy to cystamine in our rat model, and high-dose studies are now underway to determine if this efficacy can be increased. And then for the combination study to address the limitations of cystamine, we've shown that combination treatment of cystamine and everolimus for 6 months shows a better reduction in cystine levels, enhanced improvement in Fanconi syndrome markers and kidney appearance compared to either treatment alone. And we're starting combination studies of CF10 and everolimus soon. And both treatments offer the potential, I hope, to improve the lives of patients. So I'd just like to thank the lab in Auckland. So Professor Ale Davidson is there, and Pangyuk and Jawa, who were the student and animal technician who did a lot of the work, and our collaborators Herbie and Animal Facility, who looked after the animals, and of course all our funders who, without their support, none of this work would be possible. As everyone knows, it's very hard to get research funded at the best of times, and especially if it's a rare disease. So without their support, there would be little hope for this research. So thank you.
Excellent, thank you so much. We do have time for some questions, and I expect there'll probably be a few. Yes, Teresa.
Just really quick, is there a big delta between the male and female results?
Yeah, so we saw that the females definitely didn't have the same effect as the males, so they need a higher dose, we anticipate. In terms of everolimus, definitely, and CF10 probably as well. So there definitely is a difference. So, and a lot of studies are done only in males, so it's really important that we do both sexes.
Any idea why?
So there's a couple of hypotheses, I guess. It's like hormone levels could be a factor. I know that some of the markers or some of the research we're looking at into everolimus in particular, when you give it to, or females have a transporter that might affect the levels of everolimus, so there have been studies that show that it will need to be given at higher doses.
Just to add on the why, in mice we have 5 times more accumulation of cysteine in the kidney only, in female than male. Do you have the same phenomenon in the rats? And that could explain why maybe your drug is less effective in female?
We do see some of the markers increased in females. For the most part, they're equal between males and females phenotype, but yes, cysteine levels definitely are higher in females in the rat.
We have time for another question if anyone has one.
I was just curious if y'all intended to do testing with it, the cysteamine at the proper dose, like that would go with it, and see if that, like what the life expectancy may go out to for the rats?
Yeah, so we're starting those high dose studies now, so we'll see if the maximum dose would bring it completely, you know what I mean?
Is CF10 expected to go through trials like, or any time frame for that or anything?
Yeah, so there's a trial starting this summer in the UK, a very small one just for toxicity studies in humans.
Oh, toxicity-wise too, like you said the dogs had like 4 times the dose for the CF10, but what about for the whatever one that's already released? What was it called? The everolimus or whatever it was?
In terms of toxicity studies?
Yeah.
So that's already FDA approved, so those studies would already be done with that drug, yeah.
Well, that's some very exciting information for sure. So the CF10 trial is just a safety one coming up?
Yeah, it's a small one, yeah. But then after this one, it will hopefully progress to the next stage.
Okay, great. And one follow-up question. Do we have any others from the audience? Okay. Okay. And that 30 milligrams per kilogram, you said is about a half dose?
Yeah, so it's twice daily, so it's about 60 milligrams per kg, and I think when you convert that to the human dose, it's about half.
Okay. Okay.
Yeah.
Excellent. Well, thank you so much, Dr. Hollywood.